We'll introduce some of the speakers later on by our very own moderator, Dr. Rosalind Gugi. But to start off the discussion, on behalf of Boehringer Ingelheim, my name is Dr. David Kamau. I work here together with Dr. Karen Rotuk from the medical team, and I'd like to kickstart via introduction. Just a welcome note from our general manager. His name is Dr. Anthony Lau. A word of introduction, and then thereafter I'll also introduce the moderator for the evening to take us with the next session. So Dr. Anthony Lau, please.
David, thanks a lot for the introduction and the opening. I'll keep it very short. I'm the general manager and the head of human pharma. Good to see quite a number of familiar faces here this evening in the room. And also a big welcome to all of those of you who are online. So I've just prepared a few slides to show you a brief history of Boehringer Ingelheim. It's a privately owned company. The company has been founded almost 140 years ago. We have about 50,000 people working all over the world. And every year we put about almost 25% of our turnover into research and development. And that research and development is spread out over many countries, different continents. There are two divisions. There's a division in animal health and also human pharma. Now, if you go to the next slide, just a brief look. Boehringer has been expanding since 1956. We went to Brazil. We came to South Africa in 1966. And then in terms of the different business units in 2017, we acquired a part of Sanofi called Merial in the animal health part, and we gave them the part in OTC. So today we're purely research and development focused, and our research and development units are serving both animals and humans. And here in Kenya, we've been around for a while, but since 2023, we also have a scientific office here. And with that scientific office, we are operating in different fields, different therapeutic areas, like cardio-renal metabolic, so that's the topic of today, but also CNS, immunology, oncology, respiratory disease, and retinal health. So I very much look forward to some fruitful, interesting discussions today. Panelists from different countries, Kenya, Ghana, Nigeria, and the UK, and I'll hand it over so we can all kick it off. Thanks a lot for your attendance.
Thanks, Anthony. I'd like to invite our moderator for the evening, Dr. Rosalind Gugi. We also have a speaker joining online from Ghana as well, and she'll of course introduce all the panelists. Dr. Rosalind Gugi, just a high level, she's a dedicated servant within diabetes space. And of course, she's mastered a few experts to come to this evening meeting. And of course, I'll hand over to you so that you can take over the next session. Welcome.
Thank you, David, for that kind introduction. I really want to thank DI for this opportunity. It's not every day that we have to have such esteemed speakers, Prof. Ulasi from Nigeria, Prof. Mark Evans from UK, Dr. Lamti, who's online. It's amazing to actually have the experts here in person. We have quite a number of endocrinologists who are a bit biased. So feel at home as the only nephrologist in the room, but we promise to be gentle with you. And we've been talking about, when we're talking about diabetes, we talk as just endocrinologists. And then you have the cardiologists talking about the benefit of our SGLT2 inhibitors, and they've literally stole it. And then the nephrologists are like, wait a minute, no, these drugs belong to us. So how about if we all come together and agree on how we're going to use these drugs? And that is why we have such meaningful talks. So the first talk is actually going to come from Prof. Mark Evans. And you'll permit me to give quite a bit of a bio. Wow, it's interesting. But you need to understand, it's a privilege. You could be sunning yourself in Mombasa right now, but you chose to spend a day in Nairobi with us. And for that, we're really privileged. So Prof. Mark Evans is a highly accomplished consultant endocrinologist and diabetologist with extensive experience in clinical practice, research, and medical education. He's based in Cardiff, UK, and he has a distinguished career focusing on diabetes, lipid metabolism, and cardiovascular disease. He has been involved in pioneering research which explores the pathophysiology of type 2 diabetes, the clinical efficacy of blood glucose lowering therapies, and its intersection of diabetes with cardiovascular health. He has published widely in top-tier medical journals and has contributed significantly to the understanding of metabolic diseases through his work on health outcomes and epidemiology. Now, as an educator, he's deeply committed to both undergraduate and postgraduate teaching, frequently lecturing at national and international forums, and he also serves as an editor-in-chief of Diabetes Therapy, where he continues to shape the field with his expertise and insights. So who better to actually take us through the Empower program in perspective and how we can be able to actually practically approach our patients with cardiovascular metabolic disease. Welcome, Doc. You can do better than that.
No, that's great. Look, thank you very much for those extremely kind words of introduction, and I'll buy you a drink later on. They were very flattering, I must say. So, look, it's a great pleasure to be with you this evening, and I'd just like to thank BI for the opportunity to come and present this evening. So, we have about an hour and a quarter or so in terms of time, so I'm going to try and be as quick as possible and run through the data and the perspectives on the Empower program. And really the rationale for doing this is that as a diabetologist and a epidemiologist and also a health economist, there is a huge value to these medications across the spectrum of cardiorenal metabolic disease. And I'll talk you through some of our data based on real-world analyses and modeling in the UK towards the end of the presentation. But I thought I'd start off with a very interesting quote. Now, Cuthbert Collingwood, for anybody that knows British history, was in fact the admiral who led the British at the Battle of Trafalgar. Nelson was dead within 26 minutes of the engagement, and Collingwood basically won the battle. There is a commemorative plaque to Collingwood in St. Paul's Cathedral. Anybody been to St. Paul's Cathedral here? No, if you go to St. Paul's Cathedral, there's a huge crypt at the bottom with Nelson's tomb in it, and right at the back of it, there's a little plaque for Collingwood. And Collingwood said that, let us do something today which we may talk of thereafter. And I think that really was quite an interesting quote to me, because it reflects what we should be doing when it comes to SGLT2 inhibitors. Because what we do today is something that will have impact long after we are no longer practicing. And it will change and shape the way healthcare is delivered across the region. So anyway, as we heard from Anthony, cardiorenal metabolic disease is a major therapeutic focus. And I thought I'd just start off with just some top-line epidemiology. David, can we have the next, just click through the build slide? So there's a huge overlap between cardiovascular disease, heart failure, type 2 diabetes, and of course, kidney disease. And in the kidney disease perspective, type 2 diabetes is by far the most common cause of chronic kidney disease globally. It's also the most common cause of end-stage kidney disease. What's happened here? There's an overlap in terms of the morbidity and mortality. Now, what happens if you have all three, so-called cardiorenal metabolic disease? Then your survival is reduced, your mortality is increased, your quality of life is reduced, and so indeed are your costs increased. So consequentially, understanding the interlinkage between cardiorenal metabolic disease is incredibly important. And what we have with the SGLT2 inhibitors is a drug, a class of agents that spans that spectrum. And we look at the evidence as we go through. Okay, So shall we have the next slide, please? Just a quick word on heart failure. Heart failure is very interesting, really. And we said that our cardiology colleagues stole SGLT2 inhibitors, but actually it's quite useful because what the cardiologists have enabled us to do is think about the fact that heart failure is very common in type 2 diabetes. And we routinely now screen our type 2 diabetic patient population, particularly if they've got CKD, for evidence of heart failure by using an NT-proBNP measurement. It's a lot cheaper and easier to get hold of than an echocardiogram. And irrespective of your ejection fraction, there's outcome evidence with an SGLT2 inhibitor that reduces hospitalization costs, improves quality of life, improves symptoms, and also, importantly, gains overall health. There's some really interesting data, for example, at EASD just recently, saying that if you had atrial fibrillation, you had about a 28% reduction in your morbidity, mortality, and hospitalization with an SGLT2 inhibitor compared to not SGLT2 inhibitor-based treatment of type 2 diabetes. So arguably, if you've got AF and type 2 diabetes, or if you've got AF in the context of kidney disease, your first-line treatment should be an SGLT2 inhibitor. And I'll show you some more data when we talk a little bit more around these concepts going forward. But this is the EMPA-Kidney data. So the EMPA-Kidney trial I'll touch upon in a little more detail, but EMPA-Kidney was basically empagliflozin compared to placebo in a cohort of people with or without type 2 diabetes with established chronic kidney disease. And what you see with the EMPA in the blue compared to placebo in the red, there was a significant increase in time to declining renal function and necessitation of end-stage renal replacement therapy. Even look at a GFR of 85. Now, the relevance of that I'll come back to, but the important point here is that if you started up here, now these people arguably don't have CKD, but by starting here and preventing decline to here, you have a significant health and value gain, not only to the individual person, but also to the healthcare system. Okay, we'll come back to that. Next slide, please. David, oh, good man. Okay, here we are. So here are the absolute numbers in terms of years gained without need for end-stage renal replacement therapy. And look, you're talking nearly 27 years of additional life without the need for end-stage renal replacement therapy if you started 10 milligrams of empagliflozin in somebody with type 2 diabetes, for argument's sake, at a GFR of 85, right? Now, that's very important in terms of service delivery, in terms of costs, but also in terms of health gain for those particular patients that we see. Now, with respect to health economies, there's a big value. In Kenya, you've got a growing health economy. In the UK, we have an NHS that's under massive pressure. And we are tasked, just like you are here, to do more with less. And that is fundamentally what an SGLT2 inhibitor like empagliflozin enables you to do. It enables you to do a lot more, but also spend less. And that's a unique thing, because where else in investment world do you get that sort of concept? Anyway, I'll show you the data that supports that and the reason why I would advocate starting an SGLT2 inhibitor up here. Okay, let's go. Next slide, please, David, if I may. So that's that data presented in a slightly more sort of impactful graphical way. By delaying the rate of decline of GFR, you will effectively delay the progression of renal disease and progression to additional comorbidities. Now, as you delay the progression of decline in GFR, you will also reduce the burden of cardiovascular disease, heart failure, and CKD endpoints. Now, when you start an SGLT2 inhibitor, what you'll see is an initial drop in your GFR of about 1.7 to 2 mils per minute per 1.73 meters squared, that compared to standard non-SGLT2 inhibitor-based therapy, plateaus off over time, translating into that delay in progression of GFR. Next slide, please, David. So the EMPA-Kidney study was one of 3 effectively CKD-type trials in diabetes and non-diabetes. And the reason that EMPA-Kidney, I think, is really important is that it included the most multiply comorbid patient population, as well as people with relatively preserved GFRs. Now, what you see here is when you look at the proportion of people in the EMPA kidney patient population, you had a group of patients, look, with less in the way of pink doesn't show CVD, type 2 diabetes, and albuminuria compared to the other studies. So you had a much broader patient population with comorbidities as well as those without comorbidities. So fundamentally, EMPA kidney is by far, I would argue, the most representative of the clinical trials when it comes to kidney disease outcomes with the SGLT2 inhibitors. CKD, for example, was a much more enriched patient population in terms of adverse risk. Particularly, they had about 2/3 of people with established diabetes as the cause of their kidney disease, compared to less than half in the EMPA kidney trial. So that's why I focused a bit on the EMPA kidney data here, because I think it is a far more representative population to inform our clinical practice. What the EMPA kidney study also showed us from this patient population distribution, reinforcing the fact that this is a more representative group of people, in EMPA kidney, the rates of all-cause mortality, heart failure hospitalization, and CV death were less, illustrating that this isn't an enriched or highly enriched patient population. So the data from EMPA kidney you can translate into a more primary care style patient population. Because arguably, patients from, say, CKD or credence would be the sort of people that I would be seeing in clinic, or that our nephrology colleagues would be seeing in clinic, whereas the EMPA kidney patient population is much more representative of who you would see on a regular basis. Next slide, please. So that leads me on to the SGLT2 inhibitor meta-analysis, just to look at some of these data in greater perspective. Now, this is a meta-analysis of the 13 large placebo-controlled trials, including the CKD studies. So 90,000 or so participants, 15,600 did not have diabetes. The population meta-analysis was divided on the basis of type 2 diabetes, CV risk, heart failure, and patients with or without CKD. The objective here is to examine the effects of SGLT2 inhibitors on kidney disease progression according to standardized outcome definition, as well as effects on things like acute kidney injury, mortality, heart failure, as well as some safety measures that I'll touch upon as we go through. Now, the standard kidney disease definition, and Anthony will talk to this if you wish him to do so, but this is what pharma companies now have to demonstrate if you get a label for for kidney progression, and that is you need a reduction of in sustained GFR decline of greater than 50% from randomization, reduction in end-stage kidney disease, reduction in progression to sustained GFR of less than 15, or renal death. That's now what's called a hard composite renal endpoint. Some studies will include cardiovascular death and all-cause mortality. Others will also include as a broader, what they call wide renal endpoint, albuminuria, onset, or progression. Next slide, please. So when we look at some of the outcomes, these are the SGLT2 inhibitor studies. And when you look at the forest plot, SGLT2 inhibitor beta compared to placebo. Now, placebo isn't just doing nothing. Okay, so this is on top of optimized contemporaneous standard of care. So blood pressure management, lipid control, ACE or ARB, MRA, etc., as necessary. And what we're seeing, diabetes, no diabetes, irrespective, reduction in that kidney disease progression endpoint in favor of the SGLT2 inhibitors. Next slide, please. So this is the broader range population based on the studies, and you can't necessarily see this that well. But again, independent of the individual trials, there's a reduction in favor of the SGLT2 inhibitor. And importantly, the EMPA kidney trial also showed that. And why is that important? Well, not because this is a BI-sponsored meeting, but that is because that EMPA kidney patient population is very much more representative of routine primary healthcare than, say, some of the other patient studies that were conducted. But irrespective of the setting of the trial, be that heart failure, be that preserved or ejection or reduced ejection fraction, be that in diabetes, such as EMPA-REG, declare TIMI, so on and so forth, reduction in end-stage kidney disease outcomes. Next slide, please. When it comes to kidney disease progression, and this is the decline in GFR, again, very similar data, all in favor of a reduction in that rate of decline of GFR in favor of SGLT2 inhibition, irrespective of the disease setting, heart failure, diabetes, or kidney disease. Next slide, please. So this is looking at kidney disease progression as a function of the etiology of kidney disease. And these are often some of the questions that are asked. Diabetes, ischemic hypertensive kidney disease, glomerular disease, other diseases of uncertain etiology, or any diagnosis of CKD, all reduced in favor of SGLT2 inhibitors. There's an ongoing study in ADPKD, autosomal dominant polycystic kidney disease, which is funded by the ADPKD Society, looking specifically at the use of SGLT2 inhibitors in that particular etiological cohort with kidney disease, which isn't included here. There's also ongoing studies looking particularly at mortality, heart failure, and CV outcomes in people with end-stage kidney disease, defined as a GFR of less than 15. Now, that's not included here. It's not within any of the product labels at the moment, and I'm happy to discuss that when we break to have our discussion a bit later on. Next slide, please. So this is the data in terms of glomerular disease. So irrespective of whether it was IgA nephropathy, segmental glomerular sclerosis, other glomerulopathies, or any cause of glomerular disease, there was outcome benefit in favor of the SGLT2 inhibitors. So the message that's coming across is irrespective of the etiology of your kidney disease, there's outcome benefit in terms of delaying progression with an SGLT2 inhibitor. And that's seen across those three trials. And again, particularly raise your awareness of the EMPA kidney, because that's a much more representative patient population. Next slide, please. So in terms of kidney failure, so this would be the end-stage kidney disease diagnosis that we talked about. And the reason that that's important is that has capacity and cost issues and service delivery issues. And I'll come back to talk about that, if I can, to our nephrology colleagues in a moment's time. But reduction in favor of the SGLT2 inhibitors, again, irrespective of diabetes status or otherwise, and irrespective of heart failure studies or study settings. So next slide, please. In terms of CV death, again, a reduction in incident CV death, and also, next slide, all-cause mortality, irrespective of your diabetes status. So I think the key messages that are coming out of this, irrespective of your diabetes status, your heart failure status, your study setting, or your kidney disease etiology, there is realizable value in terms of health gain with an SGLT2 inhibitor. And the EMPA kidney study in particular exemplified that across a wide range patient population. So one of the questions that we get asked, and this is derived from some data from the EASD, is what happens in diabetes if you've got a GLP-1 receptor agonist? And the answer to that is irrespective of whether or not you do or do not have a GLP-1 receptor agonist in your background therapy, the outcome benefits with the SGLT2 inhibitor are maintained. Okay. Now, one of the other questions that's often asked in diabetes is what happens if you add a GLP-1 to an SGLT2 inhibitor? And post-hoc analysis of the FLOW trial with semaglutide basically showed that the effects are cumulative. So you get an additional benefit of one on top of the other in terms of some of the kidney disease outcomes. And that wasn't a pre-specified part of the analysis, and the numbers aren't necessarily designed to answer that particular question. But fundamentally, when we do our modeling activities around treatment pathways, we would consider an SGLT2 inhibitor and a GLP-1 receptor agonist as having cumulative effects. The other question that's often asked as well is, what about finerenone, or the selective MRAs? Data presented at the EASD again suggests a similar sort of thing, that A, the MRA outcomes, if you've got an SGLT2 inhibitor, are maintained, and B, what you have is that if you add an MRA to an SGLT2 inhibitor, there is a cumulative outcome benefit. The other advantage of an SGLT2 inhibitor in combination with an MRA is a reduction in incident hyperkalemia. Because across the safety analysis of the SGLT2 inhibitors, there is about a 17% reduction in the rate of hyperkalemia. There's also a numerical reduction in hyponatremia, and there have been a couple of studies using SGLT2 inhibitors in inappropriate ADH-induced hyponatremia, and you raise your serum sodium by about 3 millimole per liter in that situation. Some of the outcome benefits in terms of the tachydysrhythmia and AF may be magnesium related, because there's a reduction in hypomagnesemia that has also been seen with an SGLT2 inhibitor as a mechanistic thing in terms of the cardiac dysrhythmias. Okay, next slide, please. So going on to the safety, it's almost like I knew what I was talking about there. So if you look at the AKI events, one of the other questions is, do SGLT2 inhibitors give you acute kidney injury based on the fact that you get that initial drop in GFR? Well, the answer is actually, in terms of AKI, SGLT2 inhibitors appear to be numerically and indeed statistically significantly protective. So you get less incident rate of AKI. One of the other questions that's often asked is, do they give you urinary tract infections? Now, the data across the clinical trials is that there's no increase in complex urinary tract infections with an SGLT2 inhibitor. The main side effect that you will get is urogenital mycosis. And you will get more urogenital mycosis whether you have diabetes or not, because irrespective of your glucose status, when you use an SGLT2 inhibitor, you will induce a little glycosuria. That is the main differentiator in terms of side effects, but no increase in urogenital infections, UTIs seen. Next slide, please. Ketoacidosis. The differentiator here is that there is more euglycemic ketosis in the context of diabetes. And that will typically occur in the context or in the setting of A, relative insulinopenia, and B, an increase in stress hormone activity. So typically in the context of intercurrent illness. So we'll come on to the KDIGO guidelines, of which we have one of the key authors with us today. We will review what KDIGO says in terms of managing the risk of euglycemic ketosis. Next slide, please. If you don't have diabetes, there is no increased risk. That's one of the things to think about. Lower limb amputation. A lot of discussion following on from the Canvas program about lower limb amputation. And the data here showed no increase in lower limb amputation across the clinical trials. And indeed, with empagliflozin, no increase in lower limb amputation has been seen. In the elderly, there's a lot of people out there with heart failure, with poorly controlled diabetes, with cardiovascular disease. What about SGLT2 inhibitors use in the elderly? We published a consensus piece and a review of the evidence, I think last year on this. First of all, there is no sarcopenic effect. That's a very important thing, because if you lose lean muscle tissue, that's a bad prognostic indicator. Secondly, as I said, no increase in AKI. Postural hypotension is something that you can see. However, you can manage that by reducing the diuretic dose requirement. And across the studies of the SGLT2s, there's a reduction in diuretic dose requirement, which feeds into that electrolyte sparing effect, which is very important in the elderly. Because if you have somebody admitted with hyponatremia who's old, it's very difficult to get them out of hospital because of the complex comorbidities. So that's an incredibly important value piece. In addition, in the elderly, there's been a lot of questions about bone mineral density. Is there a bone demineralizing effect of the SGLT2 inhibitors? And again, some data at the ADA, as well as EASD, a couple of posters, showed that there was no detrimental effect in terms of bone mineral density. I'm short on time, I'll be quick. Now, what there is interesting, I'll completely digress here, there's some really good data with the DPP4 inhibitors as far as bone mineral density is concerned. So if you've got somebody that's elderly, data showed that with acetagliptin and linagliptin, for that matter, you could increase your markers of bone density and reduce bone density markers of increased turnover. So a good treatment option if you're elderly with type 2 diabetes is a combination of an SGLT2 inhibitor with a DPP4 inhibitor from a general health and bone physiology perspective. Okay, next slide, please. So putting all of this together in terms of absolute numbers of events avoided, fundamentally, you've got overwhelming evidence of benefit as opposed to risk. In terms of things like CV death or heart failure, you've got diabetes, you've got 11 avoided events per 1,000 patient years, compared to a increased risk of euglycemic ketosis, for example, of 1. So overwhelmingly, outcome benefit. In the absence of diabetes, really, it's all benefit all the way to the bank. Next slide, please. Similarly, again, when it comes to heart failure data, irrespective of whether you have diabetes or not, overwhelmingly outcome benefit in favor of the SGLT2 inhibitor. And this number here is vast, 34 events avoided in terms of CV death or heart failure hospitalization as per 1 adverse event. So that is a huge benefit risk profile in favor of the SGLT2 inhibitor. And similarly, if you don't have diabetes, it's pretty much all benefit all of the way. So an incredibly strong set of data to support the value of an SGLT2 inhibitor in clinical practice. Next slide, please. So this is the absolute numbers, benefits and harms per 1,000 patient years. So this is a slightly different way of looking at it in absolute terms. So if your mean GFR is 80, in terms of the avoided events, you get all of these avoided events. So and the reason I've focused on GFR of 80 will become apparent when I talk about the value data that we've been doing in Cardiff in a few minutes' time. Clearly, there's a big gain, even if you've got a GFR that you would consider normal. Or this sort of GFR, if you saw them in primary care, you would think, oh, that's fine. They don't have kidney disease. There's no point in putting them on an SGLT2 inhibitor. Well, clearly there is, because there is outcome benefit to be realized. Next slide, please, David. So as a consequence, what you have, the KDIGO guidelines and KDIGO recommendations include an SGLT2 inhibitor to treat everybody with CKD and type 2 diabetes, defined as a GFR of over 20. CKD, adults with CKD, GFR of over 20, with or without albuminuria, or adults with a GFR of 20 to 45 with albuminuria. In the context of heart failure, similarly, an SGLT2 is recommended based on what we call Class 1A top grade outcome evidence. Next slide, please. So when you look at the so-called KDIGO heat map, which I think is very useful, an SGLT2 inhibitor is recommended really across the spectrum. Now, the reason I've included this again is because of this. All right, now talk to why this is important in a minute or two. Because clearly, if you're here, the evidence is fairly convincing. You've got people with established disease. You've got early return on investment. Okay, next slide, please. So some practice points. So it's reasonable to withhold an SGLT2 inhibitor during times of prolonged fasting, surgery, or illness. So this is the so-called sick day rules. So what we would typically do is if you're having an operation, we would say stop your SGLT2 inhibitor 3 days beforehand, and then restart it 3 days after your surgical procedure. That's our local practice. If you develop an intercurrent illness, we'd stop the SGLT2 inhibitor and restart it when you are better. During periods of prolonged fasting. So this is something that was looked at, for example, during Ramadan. There were several studies out of the Middle East showing that there was no increase in ketoacidosis during Ramadan. And actually, it's quite a good drug to take during Ramadan, particularly when you break your fast, because of the effect. When you break your fast, you will have large calorie intake, and the effect in terms of glucose secretion is quite noticeable during that period of time. So medications are discontinued. The important thing about this is to restart. If you restart if you temporarily discontinue an SGLT2 inhibitor during surgery or intercurrent illness, the key word there is temporarily. So it is important to restart, because once you've restarted, there is all of the benefits to be realized. So when would you continue an SGLT2 inhibitor, and when is it reasonable to start it? So is it reasonable to continue an SGLT2 inhibitor for GFRs below 20? Well, from a KDIGO perspective, and certainly from my viewpoint, I would continue with an SGLT2 inhibitor below 20. Now, I appreciate that's not within the label indication. I've got to say that. But I think based on what we understand in terms of mechanism of action, there is a rationale for doing that. SGLT2 inhibitor use does not necessitate an increase in kidney function monitoring. It's another typical question that's asked. If I start EMPA today, do I need to get somebody in to monitor their kidney function next week? No, you don't, because of all of the data that we've already seen, but there's no necessity to increase. So what else can we do? What other things do we think about? Well, planned discontinuation of other medicines, as you said, during elective surgery. So typically our approach would be 3 days before. So within 72 hours, we'd stop the SGLT2 inhibitor, as well actually as metformin and an ACE inhibitor. As I said, some other practice points to think about is the reduction in diuretic dose requirement that you'll have, and also a reduction in other antihypertensive medication dose requirement. Okay, next slide, please. So from a KDIGO perspective, SGLT2 inhibitors, well tolerated. People with CKD really should have an SGLT2 inhibitor as part of the cornerstone of management, and have been shown to be cost saving across the spectrum of kidney disease, providing value to healthcare systems. And if I may, that's the last thing I'm going to talk about for the next couple of minutes. So next couple of slides, please. So let's just think about the dynamics of CKD progression. Could you run through the bill, David, please? So what happens is you've got an increase in things like diabetes, obesity, hypertension, etc., aging population. So as a consequence of these risk factors, your CKD prevalence will increase. You'll have more people with 3A, yeah? Okay, and as you get more people with 3A, you'll have more people with 3B, more people with stage 4, so on and so forth. Now, if you intervene here at stage 3B, what will happen? Okay, should we have a look, David? Well, if you just intervene there, without changing the dynamic here, you'll end up with more people with stage 3A. Next slide. So what does that mean if we then run a projection? Next on the build. So if we, for example, gave, and this is just an assumption, 50% of people with stage 3 KB, CKD stage 3B and SGLT2 inhibitor, you would reduce population prevalence of stage 3B because you delay progression. You would also significantly reduce stage 4 and end-stage kidney disease. But if you just focus on stage 3B and don't look at the stage 3A or even earlier, you end up with more people in the stage 3A cohort. Next slide, please. So what does that mean in terms of costs? So if you just focus on stage 3B, yes, there are cost savings to be realized. However, there are more people with stage 3A. Next slide. And that's the numbers when you look at it. So you'll save money with later stage kidney disease, but there'll be a cost consequence of earlier stage kidney disease. Next slide, please. So what that, if you go next slide, and next build through. So what that actually looks like in terms of end-stage kidney disease, if you just gave 50% of people with stage 3 KB, empagliflozin, for example, you reduce number of people required for dialysis. Look, very early on, by 2030, there's a reduction and therefore an increase in your capacity. Next slide. And what that translates into is very significant cost savings. So this is a UK perspective. If you use that, you'll end up with £114 million per year saved in terms of end-stage kidney disease cost, an 18.2 million reduction annual direct healthcare spending, and a prevalence reduced by 2040 of over 700 by, this is in the Welsh population, of 3.5 million people. Okay, next slide. So, however, what you really need to think about is not just those with established kidney disease, because yes, there is a reduction in costs, reduction in dialysis. So really, by 2025, once you've introduced SGLT2 inhibitors, your dialysis prevalence flattens off. Because we saw, remember that data that I showed you, within 2 years of starting an SGLT2 inhibitor in people with a GFR of 25, there was a reduction in progression to end-stage kidney disease. So you get almost instantaneous realization of value in 18 months or so. However, if you don't focus on those earlier on, you offset that value gain by treating those later on. So the key message here is that an SGLT2 inhibitor is not for people just with established kidney disease, but across the spectrum of cardiorenal metabolic disease, and gives you kidney outcomes in terms of value gain, even if you started at a GFR of 85, because it'll reduce progression through the natural history of kidney disease. So time is everything. I've overshot my time, but time is everything. And what I hope I've done is that in those last few minutes, the use of an SGLT2 inhibitor. So you'll have a clinical you'll have a consultation, maybe 5 minutes long. But if you use an SGLT2 inhibitor in that 5 minutes, that can mean the difference in terms of a variety of parameters to health between victory and defeat. And I think this is a really good quote when it comes to thinking about an SGLT2 inhibitor. In the short time available, prescribing one of these agents has a huge impact across all stakeholders. Thank you.
You can tell a lecturer, they get so passionate, they forget about the time. Right, just one question. Are you trying to say SGLT2 inhibitors are the new statins for heart failure and CKD patients? Is that what you're saying? I think he's campaigning to be on that task force for KDIGO guidelines, because we've seen what the guidelines are, and I'm glad that we actually have a member from that task force, because I think you're trying to change their guidelines, and we'd like to hear from the expert, the nephrologist. I mean, he's raised a couple of issues. We focused on CKD stage 3B and on 4 and 5, actually just CKD 3B and 4 with regards to the use of SGLT2 inhibitors. So the question is, when he raised the question of they're going to try using the SGLT2 inhibitors in patients in stage 5, what's the benefit if you're already on dialysis? Are we looking at perhaps more complications, or do we think we're using it for the cardiac benefit rather than just the renal benefit, since we don't seem to understand the pathophysiology clearly in the heart, but we know that it's beneficial. But now in the kidney, if you understand the pathophysiology, then what benefit does it give us in the kidney? And then another question is, you have a patient, he's on an SGLT2 inhibitor, gets, say, a euglycemic DKA, and you know that they have that, you want that benefit, so they're going to stop. When are you going to restart it? And we've seen all the trials are looking at patients with advanced kidney disease, right? And yet he's saying that it's showing benefit even in patients who apparently don't have CKD. So you wouldn't actually want to do a trial on patients who don't have kidney disease, and you're giving them a drug, they'll tell you what's the additional benefit. Why are you giving me an extra drug? So I want you to talk in the context of the cost implications when you're in a third world country. He says it saves cost. I'm sitting in the Ministry of Health, and I want to introduce this policy where I introduce, for anyone who is at high risk, who's diabetic, we've seen the greater benefit in those who are diabetic compared to the non-diabetic. I want to give you an SGLT2 inhibitor. How are you going to convince me from a policy point of view that I'm actually going to save money, right? Because I'm reducing the number of people who are ending up on dialysis and transplantation. So those questions I have directed to none other than Prof. Ifeoma Olasi, who's a professor of medicine at the College of Medicine, University of Nigeria, and she has affiliations with 2 teaching hospitals. She's an international advisor at the Royal College of Physicians, we aspire, London, and she's the deputy chair of the ISN Advocacy Working Group. She's also a member of the WKD Joint Steering Committee, INET and ACTS committees. You'll tell us what those are. She served in the ISN EXCOM 2021 to 2023, and she's also involved in several research initiatives and projects on kidney and NCDs. She's a site PI of the H3 Africa Kidney Disease Research Network and the PI of the Health, Hereditary and Environmental Research Initiative. She's also an associate editor of the American Journal of Kidney Disease, Transplant International Journals, and the Journal of the American Society of Nephrology. I mean, we are in awe of having you in our presence, so thank you very much. And perhaps we'd like, from your perspective, in terms of improving outcomes in CV, renal, and metabolic conditions in primary care versus the discrete problems like we've talked about in the African context. Can we believe what Prof. Mark has said?
Thank you very much, Dr. Ngugi. And I want to thank DI for having this forum because it's always good to spread knowledge. If you don't have knowledge, you do the wrong things. So I want to thank you, the GM of DI. And would I say my colleague, Professor Evans, the diabetologist, like Dr. Ngugi was saying, these days we take ownership of SGLT2. I think the diabetologists are in the periphery. The cardiologists may be chasing after us, but I think where the thing is now is renal medicine or the kidneys. I would want to give a background sort of so that we begin to understand why we do what we do. We don't talk of kidney disease these days. We want to talk of kidney health. You get it? Previously, our energies were put on looking at kidney replacement therapy, you know, at the end point. But now we want to start early to make sure we don't let you get to the end stage. So we are talking of your kidney health. You get me? So let me take on the cost because that's what most of the people want to hear. There is so much cost reduction when you prevent your patients from getting to end stage. You know how expensive those kidney replacement therapies are? Most countries in Africa cannot afford it. Yeah? Most countries can't afford it. In South Africa, that is doing a lot of things, they kind of limit the number of people they put on KRT, unless you have your own money and you go private. Not to talk of the other countries that can, in my country, they can't even afford it. You pay out of pocket. So, and the other thing you must bear in mind is that people that are at the level of stage 3B or stage 3A are like, people would say, every lizard lies flat on the ground and is crawling flat on the ground. So you don't even know which one of them has belly problem, right? So in this room, if we were to do EGFR, you may find out that some of us are in stage 3A or stage 3B, and we are functional, working. So when you leave people at stage 3A and stage 3B, what do? They work, right? They contribute to the economy of the country. But if you have people debilitated in stage 5, the whole family, the wife, the mother, the children, everybody participates in taking care of him. Isn't that so? The wife stops work, the man that is ill is not working. So you can imagine the amount of revenue we are losing. Why I'm saying this is that we have to look at the cost effectiveness of what we do. Our decisions have to be cost effective. I'm a preventive nephrology protagonist. Yes, we must prevent kidney disease. That's where I stand. And I keep talking about screening people that don't know, the early detection so that we can handle them. And that is what he was saying when he was showing us the 85 meals per minute. Anybody who has 85 EGFR of 85 meals, I'm not even sure mine is up to that, is normal, right? Right? So we want to pick people at that stage so that we can stop them from progressing, right? I'm so excited that, and so are other nephrologists. A few months back, about 4 of us or 5 of us from different continents were asked by Nephrology, Nature Reviews Nephrology, to write on the new therapies we have for diabetes and chronic kidney disease. And we all wrote independently. If you read that publication, you will see that we're all talking about similar things because it's the same thing. We are also happy that now, apart from ARBs and ACEIs that we got like 20 years ago, we have new drugs to work with. We are so excited to have new drugs to help our patients, right? So excited. And maybe the cardiologists and the diabetologists are thinking we're taking things away from them, because invariably, like you said, the DM patient rolls on to CKD and has stage 3 or stage 3A or stage 3B or 4 that eventually comes to us. That aside, where I want to take us back to is what we do at the primary care level. It is multidisciplinary management. We want people identified at that primary care level so that the right things can be done for them, that they don't even have to progress to come to me. They will, if you looked at the chart where he showed somebody was added 26 years to the person's life. If you add 26 years to my life, I think God has done a whole lot for me that I should be leaving the stage, right? So the point is that CKD is at, or nephrology is at a precipice now. It's kind of in the center of the action, unlike before. We have a lot to manage our patients with, and those managements are very cost effective. So tell your people it's so cost effective because you're having more people working, more people being able to contribute to the nation instead of being on the dialysis. And outside even being on dialysis, we are all talking about climate change and what is happening with our climate. And we know that dialysis contributes a lot of energy, negative energy to the climate, right? So that is taken aside as well. So if you begin to count the costs, the small costs that we can put our pulse on, then we need to stop our patients progressing to end stage. I don't know if I've handled all the, is there any more I missed? And then stopping, and then we're talking about when do you, if a patient, when do you start and when do you stop SGLT2 and when do you start? Yeah, if your patient has a serious infection or is going to a theater, as he has already mentioned, you can stop temporarily. As soon as he comes out of that situation, you can put the patient back on it. We don't worry about SGLT2s reducing the blood pressure or reducing the EGFR, because we know that that reduction in EGFR is part of what it does in prolonging your kidney function for a long time. But unless the reduction is so much and goes for so long, then you begin to look behind it to find out if there's something else causing it, not just what the eyes can see. What else do you want to know? Okay, the jury is not out on that. There's a study going on using SGLT2 in patients on dialysis. That is still on because we are talking of evidence-based medicine. And I'm so happy now that most of our studies, before, you wouldn't include patients with CKD in your studies. They were all excluded, right? But now they are now included. Same thing is happening with dialysis, but they are now included and they are looking at it to see if there are merits to giving them SGLT2.
But knowing the way SGLT2 inhibitors work, what would be the benefit in, what are we trying to achieve in CKD stage 5?
Do we know?
If we are thinking of, I mean, you must have a hypothesis as to why it makes sense, CKD stage 3B and 4. You're preventing progression of disease. We already have end-stage disease. What are we hoping to achieve by giving these drugs? Even pathophysiologically.
You know, the thing about SGLT2 is that we don't even know all it does.
Yes.
We are like the 6 blind men touching the elephant. This touches it and says it's very much like a tree or it's very much like a trunk. We don't quite know the much it can do. But I understand your point, if the person is at end stage. But you know that even at end stage, they do have some reserve. Those hypertrophied nephrons can be preserved because you know the problem is the intraglomerular pressure. That is what kills the nephron. So they can be preserved. And then you have a little, maybe if the patient may not be dialyzing like 2 or 3 times a week, You may reduce it to once a week because you have preserved the little nephrons that are left there. Yeah, that's one thing I think may be happening with that. Yeah.
It's something to think about it. One of the questions that commonly comes up, and I think maybe we'll have that in the Q&A,
Yeah.
which I want you to think about, is you have a patient, 65-year-old diabetic, has heart failure with reduced ejection fraction. And so the cardiologist starts them on empagliflozin, right? And then when you do your UECs, you find the eGFR of, say, 15, all right? So from your point of view, would you stop? Cardiology says, I want to continue. What would you do? It's something to think about. You can answer that in the Q&A.
Okay.
All right.
Okay. I'll answer that, but it's easy to answer.
Excellent.
Okay.
Thank you very much.
Thank you very much for listening.
And we've learned something new, kidney health. It's not about kidney disease, it's kidney health. And remember, we're talking about quality of life. So on that note, I mean, we're talking about the role these drugs have to play. And, you know, for the longest time, as diabetologists, I can tell you, we've always focused on the glucocentric approach. And now we're saying, what's killing our patients? It's heart failure. It's a chronic kidney disease. So let's hear from Dr. Roberta Lamptey. She's passionate about diabetes self-management education. Her research interest is focused on improving outcomes at the primary care level. She's currently involved in a multi-center study aimed at improving outcomes in cardiometabolic diseases in low- and middle-income countries. She's a consultant for the Kolebu Teaching Hospital and a part-time lecturer at the University of Ghana Medical School. She received her training in diabetes from Cardiff at the postgraduate and master degree levels, graduating with distinction at both levels. She has received formal training in clinical epidemiology from Utrecht University. She's also the current chair of the Ghana chapter of the Faculty of Family Medicine, and she serves as a diabetes expert to the NCD Control Program of Ghana. Now, Dr. Lamptey, I hope, you're online. A couple of questions. I mean, we're talking about this at the primary care setting, and we'd want to know from the setting of Ghana, what is your practice with regards to the role of SGLT2 inhibitors? Are we talking about kidney health, cardiovascular health, or for you who sees quite a number of these patients who may not necessarily be at high risk, what is your practice with regards to these patients? How often are you picking kidney disease? What is your approach to these patients? And then from a diabetologist point of view, in terms of the cost implications and also its ability to lower the HbA1c, what has been your practice?
Okay, thank you so much. It's a lot of questions all at the same time. So I'm going to try and take them one after the other, but if I forget any, please remind me. My personal practice, first of all, I think the previous study hit the nail, previous two studies really hit the nail on the head. We actually don't know how many people really have kidney disease just because of the situation we find ourselves. Where I work in is a low resource setting. If you want to screen somebody for kidney disease, you want to do UACR, you want to do BUE and creatinine, those are not covered. I mean, I'm not talking about paying for dialysis. I'm talking about screening, because stage 3 kidney disease, the people are functional, it's asymptomatic. So you don't even know the burden. So for me, in my practice, my focus is always prevention, prevention, prevention. Prevention starts with early identification. And early identification means being able to pick them up. So how do you identify kidney disease? Yes, most people here will say that it needs to be chronic, so you should have had it for 3 months. But I want to draw your attention that it is possible to pick it up even before 3 months. And the definition is end all. So it's not just eGFR. Sometimes we will only look at the eGFR, but sometimes it's end a reduced GFR or albuminuria persisting for 3 months or less if there's evidence of chronicity, change in the kidney size and all of that. So I want to draw attention to that. Now, in sub-Saharan Africa, in Ghana, where I work, more than 50% of adults aged over 50 have hypertension. So yes, diabetes is a leading cause of kidney disease, but so is hypertension. And if more than 50% of the adults walking into your facility have the condition by data, then you should have very, very minimal threshold levels in deciding on who you want to screen and who you want to have that discussion with. But that's not the only point. In sub-Saharan Africa, more than 50% of people over the age of 60 years have more than one chronic condition. That means they have multiple long-term conditions. So they have hypertension and they also have diabetes, or they have hypertension, diabetes, and HIV. So what am I trying to say? In my practice, my threshold for trying to screen for kidney disease, very low. Thank you. So I put together a few slides. I don't know if we can quickly run through that. So one of the reasons why it is important for me not to miss CKD, building on the data that I've shown you. I mean, I do have training as in epidemiology, so data is important to me. It speaks volumes to me. But also the real patients. I work in primary care. I'm a primary care physician. I am a diabetologist, but first I'm a primary care physician. I see the patients. I see them. I have a relationship with them. And I want to bring one of my patients I saw very recently, and I won't forget. So I had seen this patient in the ward. Later on, I'll tell you what he had, but we are discharged him, and it's a small community. So I'm walking down the streets, and he sees me and he says, "Doc, do you remember me?" Next slide, please. So, in fact, he didn't know that he had been keeping me awake. Why? Because this was a young man, 30 years and under. I think he was about 29 years old. And long story short, we diagnosed him with CKD. Going back, he had been diagnosed with hypertension. He felt well, he was young. He decided, I don't have hypertension. It's not my portion. Decided to take herbal medicine, felt well. And by the time he was coming to us with nausea and vomiting, it was end stage. So then I took my time and went down. But the fact of the matter is that when it comes not just to chronic diabetes, which we are focusing on today, you must remember that chronic metabolic diseases, hypertension, diabetes, the burden is borne by people less than 30 years in sub-Saharan Africa. And that's what's facing us. So don't focus on just the numbers, but focus on the patient's quality of life. So for this patient, my goal was, how am I going to preserve his renal function? What is left with it? How am I going to preserve his quality of life? What can I do so that the next 30-year-old I see, the story will be different? And of course, it starts with self-management, education, and counseling. When he was diagnosed with diabetes, what was he told? What was the implications? Did he understand the importance of monitoring and checking? Next slide, please. So what do I do? As I said, my focus is on event-free survival, quality of life. Next slide, please. So after identification, I already said, next slide, identification is important to me. What do? I slow down. You can see from the picture I'm showing you, it's really very fast. Believe you me, and in primary care, in low resource setting, sometimes we are on a roller skater. We can't help it. But if you pick somebody with a chronic condition, you pick CKD, whatever stage it is, the first thing I do is slow down. Next slide. Because if you don't slow down, if you don't take the time and look at that patient, make sure they understand what you are communicating, the implications of failure to commit to therapy, so that they can more easily make the decisions between, I am going to cut back on that salt, or hey, no, I am going to learn how to cook So I don't rely so much on commercially prepared food. And I'm going to stop buying credits for TikTok and WhatsApp so that maybe I can afford an SGLT2. They can actually see the picture well and understand. Then we are going to get up and end up with people that come like Kofi, my 29-year-old, and I had to break it down when it was probably way too late. And people need to understand herbs and offending agents. So for me, after identification, slow down, let them understand the journey ahead, how fast CKD can, end-stage CKD can come, or how slowly, the requirements for additional testing, and focus sharply, not only on the numbers. Yes, it's important. What's the EGFR doing? What's the UACR doing? But focus on the whole human being and their quality of life. What is in their world? What is their level of education, literacy? Can they get it? Next slide, please. Can I have the next slide? So for me, my best buys from the latest guidelines we've been talking all about. The first thing is I just love that word, grade. So GRADE is an acronym which stands for Grading of Recommendations, Assessments, and Development of Evidence-Based Guidelines. So what does GRADE tell you? If you see a guideline that has been developed and they use GRADE, believe you me, it's going to tell you the hierarchy, the kind of studies that were used in coming to that conclusion. But not only the hierarchy, because you can have an RCT where the randomization was rubbish, there was no blinding. It's an RCT, all right, but the quality is very low. It may not apply to your setting. So not only will it tell you the kind of studies, but it will tell you the quality of the work. Was risk of bias assessed? Was there directedness? Does it apply to your population? Is there publication bias? So that when you are given the guideline and it tells you this is 1A, you know you're standing on something solid. 1A, meaning that that evidence has been collected from a systematic review of randomized controlled trials. And that evidence, that estimate of the effect size, is unlikely to change given further trials. So when I'm reading a guideline and I see 1A, I sit up. So for me, that's one of the things. The current guidelines, great. And then building on the previous discussion, the previous speakers, what I have already said, early detection, prevention, integrated care, the whole human being, what is in their world, what can they afford, what is their beliefs, drugs, what, you know, integrating the care. The cardiologist is talking to the nephrologist, we're talking to the cardiovascular specialist. And then the next thing for me is the numbers. I mean, how many times have we told people that blood pressures of 120 is normal? It is not. It is not. Normal blood pressure is less than 120. Actually, your risk for cardiovascular events start to rise from 115. And numerous studies have shown us that you want to get that diastolic below 80 if you are dealing with any of these chronic conditions. And in fact, the current, I think the ESC guidelines, they even go low and they say from a diastolic of 70, you should be thinking about elevated blood pressure. And the Americans, following on from Sprint, have already said that even if the systolic is below 130, the systolic is within normal levels, and the diastolic is 80, it is hypertension. So what am I saying? It is important to pay attention to those numbers. And if you're treating somebody with CKD, you need to drive that systolic below 120. You need to use RAS blockade. I know today there's been a lot of focus on SGLT2, but you need to get that RAS blockade on board. You need to get those statins on board. And of course, to get the SGLT2 inhibitor on board. And this is a 1A recommendation. If you have a patient that has CKD, that has type 2 diabetes, with or without heart failure, an EGFR of 20 millimole per minute per 1.75 meter square or more, they must be on an SGLT2 inhibitor. It's a 1A recommendation. Next slide, please. So my final thoughts for me, I mean, I'm passionate about self-care. I'm passionate about self-management education. And sometimes, yeah, we wish it didn't have to be, it doesn't have to be all, you don't have to go all out. But when you're dealing with quality of life, what could potentially happen? You need to have the patient get it, that you need to pull it from the roots and get it out. That blood pressure needs to go down. You need to get the albuminuria down. You need to get the sugars controlled. And it's a lot of work. But I also like the low-hanging fruits. Things like sleep, things like less stress, things like biofeedback, checking your blood pressure, understanding your numbers. Those are easy. Things like getting a partner, somebody to coach you, getting a group, doing it together in the community. Next slide. Next slide. So my apologies, sure I've run out of time. But when he asked me, Doc, I was on the streets. Do you remember me? He was thankful for the time I took to let him understand. I almost told him, you don't know how many nights you have kept me awake. Because the data is there, my people. The data is abundant. It's not for lack of information. We know Black people are salt sensitive. We know hypertension drives CKD. We know herbs. And yet still, the burden is borne by people under 30 years. Way younger than I am. I said, Doc, do you remember me? I smiled and I said, yes, how are you doing? I couldn't look him in the eye and tell him, you have kept me awake several nights, thinking, how do I change this story with my research? Yevu remesi, asante sana.
Oh, I would want to be treated by you. You're so passionate. I now understand the concept behind. I never used to understand about family physicians. I'm like, now we're going to start fighting for patients. But you go the extra mile. There's that individualism that you have, that you take the time to take care of patients, and for that we appreciate you. I mean, you've covered that very well. Remember, at the end of the day, don't treat the disease, treat the person. Now, in the interest of time, we were going to actually have a few cases, but we're actually going to throw them back to the presenters. So I'd like to invite Prof. Mark Evans and Prof. Ulasi. I have a couple of questions. It's interesting. Thank you so much to our online team. We actually have 294 people online who have been listening in, and you can tell you it was definitely worth coming to Nairobi, right? Yes. Always a wonderful time. So on that breath, I'm going to throw the first question towards you. Dr. Gobina asks, you talked about the cost saving analysis and wants to know if you've compared settings with out-of-pocket payments versus setting with health insurance. I mean, are there studies looking at that? And given the current costs of access to these drugs, is there justification to actually give these patients with limited resources this medication? I mean, you've talked about it's life-saving, but what about those ones vis-a-vis out-of-pocket versus health insurance?
Great. So thank you very much for that question. Thank you for everybody that's attended and listened this evening. So the context of the study we did was on the basis of Kidney Association Wales asked us to look at what were the cost implications across Wales if we were going to if the kidney physicians were going to advocate broad uptake of SGLT2 inhibitors across a wide range of CKD patients. So what we did was we looked at UK settings, looked at prevalence in Wales, looked at uptake of 50% as a sort of, standard conservative approach in people with chronic kidney disease defined by CKD stage 3B. And the setting of this study was based on UK NHS parameters. And the outcomes that you saw were a reduction in end-stage kidney disease requirement, reduction in renal replacement therapy, quality of life adjusted year gains, reduction in hospitalizations and delayed progression. And the nephrologists that we spoke to were very happy about that because they were quite relieved by the fact that there was a flattening out almost of end-stage kidney disease renal replacement therapy requirements. So as in Kenya, as across Africa, renal replacement therapy is the most expensive individual thing that you have. Costs the NHS about £38,000 per year to have somebody having renal replacement therapy. However, what the nephrologists were surprised by was the increase in burden of patients. And what that really is the fact that, as you were saying, prevention is unquestionably better than cure here. And as our previous speaker mentioned, the point here is if you have an SGLT2 inhibitor introduced early within the treatment paradigm, you will delay progression. Now, from the perspective of low to middle income countries, particularly where you have out-of-pocket expenses to incur, it's much better to invest early rather than have to manage the consequences of lack of investment later on. So unquestionably, I think those data that I presented speak to two things. One, the need for early intervention, and two, the value that that achieves across all perspectives. Now, I didn't go into great detail, but those value metrics are based on things like carbon emissions, hospitalizations, water utilization, out-of-pocket expenses, as well as family and carer consequences. So, you see, by delaying progression of CKD, at the later stages, the value gain is you reduce progression to renal replacement therapy. At the earlier stages, you reduce the incidence of heart failure, cardiovascular disease, hospitalizations due to cardiovascular disease and heart failure. So there's a win across the entire economic spectrum. Now, you'd ask about what drugs to use, and this goes back to the business about quality of medicines as opposed to quantity of medicines. So we, in Europe and UK, we were part of Europe for a while, would have branded medicines. And the reason we have branded medicines is because you have a predictability of excipient content. And I talk about this a lot, so-called DMF grade or drug master file class grade medicines in economies where you have lots and lots and lots of generics. Part of the issue that you have is you're not entirely sure what is the quality assurance and quality and control of excipient content. And it's excipient content that gives you unpredictable side effects. You know, predictability of molecule is pretty straightforward, but excipient content causes you the problems. And this is why we'd advocate the use of appropriately evidence-based medications.
Thank you very much. What you've said is very correct, but I'll look at it from the perspective of my colleague in Ghana, my colleagues in Kenya, my colleagues in Nigeria, and other lower and middle income countries. Most of us pay out of pocket, yes? So since you're paying out of pocket, the branded is very expensive, right? My proposal is to BI. Some companies have produced generics and they also produce branded. If you did that for us, we'll be sure of the quality of the generic we are getting. Referring to what you talked about quality. Yeah? Because we simply have to do that. We simply have to do that because this is where we are at. We have to face reality. Our governments don't take care of healthcare. For example, WHO says you give about 5% or whatever to healthcare. My country reduced from 3% to 1.5% for healthcare. What are they going to achieve? Absolutely nothing. Coming to the cost effectiveness of using SGLT2, there's a recent study from the US, because they keep talking about screening targets to screen the people you know. In Africa, in so many of the low-income countries, we do not know the target group to screen. I'll give you an example. When I started off in nephrology, a colleague of mine said to me, because you know in Nigeria we have so many ethnic groups, and I happen to be from the Southeast, said to me that all the patients they get, he lives in the Southwest and works in the Southwest, are from the Southeast with kidney disease. He said to me, Ifeoma, what are you people doing there? It was a challenge for me. Luckily, at that point, ISN was sponsoring some research, and I did something, and I found out that indeed, chronic kidney disease prevalence is high. And as I was doing that, on the back of that, Apple 1 came out. And I was at this conference in Vancouver, WCN conference, and I was met by people from Israel. Professor Skoreki's team met me, and we did a study. And we found that APO1 is high in Southeast. And the most recent study that we did with History Africa, which is now being accepted in New England Journal to be published, it's coming out anytime, shows that actually in the Southeast, we have the highest prevalence. Of what I'm telling you is that about 40 to 50%, if we are 10 in this room, Igbos, about 5 would have double allele. So they are predisposed to kidney disease without doing anything. You get it? As soon as they add a little thing, then they have kidney disease. So that is where.
Are you saying at the end of
You know,
this?
I think that's really interesting. I've seen those data and the A1 and the APO-A1 homozygosity allele. It's quite interesting because there are differential population prevalence risks of kidney disease. And I think the answer to your one of the answers that I've always thought of every time I've been to various parts of the world to think about how governments deal on a population basis with health and health inequality, because that's a big issue at home. And I think one of the things to lobby for isn't necessarily for pharma companies to do things differently, but also to think about how you lobby government, because there is a very strong argument, I think, for certain groups of medicines to be considered as core medicines that your government should reimburse irrespective of your economic status. And I think SGLT2 inhibitors are one of those medicines because you've got so much outcome evidence across such a wide spectrum of disease, and particularly where you have differing population prevalence and access and all that sort of thing. If you're looking to address equality, if your government, and we're in the same situation, cutting down per capita GDP expenditure on healthcare, it's not so much about spending more, it's about spending what you have wisely. And I think including an SGLT2 inhibitor, a quality assured SGLT2 inhibitor, as a prerequisite that is supported governmentally within a small group of evidence-based medicines would be the first step.
Okay, great. Can we
Let me
just
just add one more thing?
one final one?
Pulling us back. The
We have
final
like
one.
50 questions.
The WHO should recognize chronic kidney disease as one of the priority diseases. If they do that, the governments will align.
Yes.
That is the main problem. As soon as they put CKD as one of the priority diseases, they will align. So we need them to do the right thing first.
So since you're head of task force for KDIGO and you work in and you're doing quite a bit of research, I think the challenge is thrown back to you and those of us in low and middle income countries. The only way government can actually recognize CKD as a problem, as a burden, is if we demonstrate it. So research at the end of the day, demonstrate that there's a problem, then we'll take notice. Now let me change gears a little bit.
I think the part of the issue just about CKD
Mark, we're never going to get through this
you know,
evening at this rate.
I'm hungry. Look, part of the issue with CKD is recognizable as a disease. Up until very recently, we've not been able to do very much about it, apart from manage risk factors. But what you now have with the SGLT2 inhibitors is a disease with a solution.
Yes.
Not only a solution, but a solution that provides exceptionally good value. So I'd agree entirely with you. Now is the time.
And FYI, for us in Kenya, our current guidelines includes SGLT2 inhibitors. So it would be good for the other countries to actually emulate the same. Now, a couple of things, Mark. Keep your answers short, right? Because quite a number of, we have so many people online who are just sending these questions fast and furious, and you've only talked to one. So Dr. Mohammed Sood from Mombasa, who's a nephrologist, says you've given an excellent presentation, but he asks that once you ingest 10 milligrams of empagliflozin, peak concentration takes about 1.5 hours. Now we're seeing drug combinations of 5 milligrams twice a day. Is this going to affect the peak concentration of the drug and its pharmacokinetics?
Short answer, no.
No. And the 10 milligram is okay for renal protection, for kidney protection. 10 milligram, you don't even need the 25.
Okay, yeah, that's excellent. Now that you have the mic, we have Dr. Gobina from Cameroon. He's a nephrologist. And given the mechanism of action of SGLT2 inhibitors, is there any rationale to the use of in anuric patients on hemodialysis, the use of SGLT2 inhibitors?
That's what we looked at when we talked about,
Yes,
you know,
earlier.
because when you say that the person is at end stage, what you're saying is that most of the nephrons are gone. But even within that, most of the nephrons that are gone, there are still some nephrons that are hypertrophic that we may be able to harness. I'm not saying let's wait until the study going on comes out. Then we can say categorically that there's nothing to achieve by giving them.
Yeah, I'm not sure it would necessarily do much from a kidney function perspective, but what I would be interested in is the heart failure and CV outcomes. You know, so
this is my question earlier. That at the end of the day, what's going to kill you, right? It's heart failure. So keep it on. We know the benefits.
Because the other thing you see about SGLT2s in early CKD isn't so much delaying progression to end-stage kidney disease, but it's your all-cause mortality and CV, because they're the things that cost more because simply more people get them. And the important thing about health isn't so much saving money, but it's gaining health. And what you do with an SGLT2 inhibitor is potentially both.
Great. So let's ask Dr. Roberta. There's one question here from Dr. Acharya, who's an endocrinologist based in Kenya. What's your experience with regards to the use of empagliflozin in patients with type 1 diabetes? Are you using it? Is there any benefit? We're looking at side effects. Is there a role for the SGLT2 inhibitors in patients with type 1 diabetes?
Okay, thank you so much. So that's an off-label question. An off-label use for now in Ghana where I practice. Unfortunately, I'm not on the ground, so I can have a one-on-one chat with you, and I don't think it's appropriate to share my personal experiences with it. But from where I practice currently, it's off-label. For more interesting though, for children who have type 2 diabetes, then you get some bang for your money. But if it is type 1 diabetes, it's off-label. Thank you.
Yeah, so very quickly, we do use a little bit of SGLT2 inhibitor in type 1 diabetes. The data from the registrational trial showed more time in range, less hypoglycemia, weight loss, reduction in insulin dose requirement at the expense of more in the way of euglycemic ketosis. Because remember, in type 1, you are in a state of not only relative, but also absolute insulin deficiency. So fundamentally, we don't use an SGLT2 inhibitor in type 1 diabetes. That being said, if you have people who have heart failure with type 1 diabetes in the background, or people with CKD with type 1 diabetes, we will use an SGLT2 inhibitor from the cardiorenal perspective, accepting the fact that that is a little bit of a leap of faith, because there is no evidence in type 1 diabetes with CKD, heart failure, etc., because type 1s were largely excluded from all of those trials that I showed you.
Yeah, talking about that, I just recently reviewed, because it's been accepted, so I can talk about it. Recently reviewed a manuscript in JSON where somebody used acetazolamide, which has similar actions as SGLT2. And he used it in type 1 diabetes because it doesn't have that effect of euglycemic ketosis. And he showed that there was benefit. So some more things are still coming out. So
on that note, there's a question here to Prof. Lassi from a Dr. Aishatu Nalado. He wants to know the role of SGLT2 inhibitors in conditions like lupus nephritis and sickle cell disease, because it's very important to retard kidney disease in such patients.
Actually, he showed the data. You use them. Yeah, it's effective in all ranges of diseases. EMPA-Kidney showed that. And that's one thing he tried to portray. EMPA-Kidney is so good that it cut across. So you can kind of generalize and use it in so many. So you can use it in lupus. You can use it in all that. There's one point I wanted to make concerning, you just reminded me of what Roberta said about talking about SGLT2. We don't use SGLT2 in isolation. Your patients would have been on ARBs or ACEIs, and then SGLT2 is added, is an addition onto what your patient is. And You know, we now have 4 pillars, so many other drugs to add on to achieve a lot more. You also mentioned all of that. So we still start off with ARBs, ACEIs, unless there are reasons like some adverse effect or some of them have terrible angioedema that you may not want to use it in them. That's where you don't use it. But basically, our patients who are on SGLT2 are already on ARBs and ACEIs. Thank you.
I'm just wondering, at the rate we're going with the SGLT2, by the way, it's fine. We lent you the drug. So diabetologists discover the drugs and then we lend it to you. Just as a note, we have a comment here from our diabetologist who's in the room with regards to the role of SGLT2 inhibitors. And one of the questions she wanted to know was, we have these patients who get AKI, okay? And we say you have to monitor their kidney function because they are at risk of CKD. So you've got a pregnant mother, she had gestational, say preeclampsia, had an AKI, got better. You monitor this patient. Would you start thinking of people who are at high risk and perhaps give them SGLT2 inhibitors?
From the data, there's for AKIs, it's not contraindicated. But you know that every management is individualized. Yeah, it may be okay for you and may not be okay for the other person. So management is individualized when you're using it. It doesn't have the problem of hyperkalemia and all that ARBs have. SGLT2s don't have it, and you can use it in. You can use it in AKI. There's another thing she mentioned about her patients not being sure if it's AKI, AKD, CKD. AKI, of course, you know, is acute kidney injury. AKD, you know, is acute kidney damage and disorders. AKD is between AKI and CKD, right? And we know that both AKI and AKD are risk factors for CKD. If you don't handle them properly, those patients progress to CKD. These are the patients you want to stop from progressing to CKD, for your question. Okay, thank you.
Yeah, so your question is really interesting because there's this whole business of rapid decliners as well. You know, and one of the great things of SGLT2 inhibitors that you can have is it can delay your so-called crash landers, particularly with you know, advanced CKD, you know, stage 4, which we didn't really incorporate in the discussion here. But when we were having our meetings with our nephrology colleagues in Wales, that was something they were particularly interested in, because the huge cost comes if you have a crash landing end-stage kidney disease. But if you've got someone on a GFR of, say, 25, and you started on EMPA-10, you've got more time to plan things like vascular access, what form of dialysis you're going to have, how that's going to work in terms of all of those other things. But in answer to your question, yes, I do use an SGLT2 inhibitor as a sort of protective intervention in people I would consider at risk of progressing to full-blown CKD, such as somebody who, for example, had AKI secondary to preeclampsia or something else.
Yeah, thank you for that response. I have another question. So in our setup, we're having more younger patients coming in with type 2 diabetes. So I have 2 groups of patients here. A lot of this type 2 are lean, type 2 diabetes. So the role of SGLT2 in these patients, because a lot of the risk factors, obesity and all that. And then the other younger population who we're having are now in the reproductive health. So the pregnancy, the breastfeeding mother. So do we have any data on that that's coming out that we can sort of safely use probably in the breastfeeding or in the...
Yeah, actually, I did some work on GDM, but it was something different for IDF. No, I don't have data on that. But I'm just looking at it. You know, when you have the slim DM, is it a type of type 1 or people that have pancreatitis or something or starvation?
Type 2.
There's still
as compared to the usual insulin resistance that we have. So they tend to do well on the SUs. But now the question is with this SGLT2 inhibitors, because again, in our setup, we don't have C-peptides that we can do to at least see if these patients are now completely deficient or absolute or relative deficiency in that sense.
Again, I would say the same thing. Management is individualized. Maybe he will know from his own practice. I don't handle such patients, but management again is individual. If it's type 2 and responds very well to that, that's fine, because you can actually use SGLT2 to treat your diabetes, right?
And then they get pregnant and you stop. You don't have evidence.
Last word on
Cutting
this.
short.
Very short, because
Cutting short.
So answer in pregnancy, not labeled. Same as the GLP-1, GIP receptor agonists. If you're a pregnancy or childbearing age, you need to be talking about particular pregnancy avoidance and all that sort of thing. Now, just we use the GLP-1, GIPs a lot in women with PCOS and obesity to increase fertility. But again, talk about the importance of contraception and being aware and testing regularly and all that sort of thing, making sure that if you are on these drugs, you do not become pregnant if at all possible. Now, what you talk about in terms of the epidemiological classification of type 2 is the Swedish EPI data that showed you have those 5 different classifications. As long as you're not absolutely insulin deficient, then I think you can perfectly use an SGLT2 inhibitor very comfortably, cognizant, of course, as with anybody with type 2 diabetes, lean, obese, or otherwise, of sick day rules. The only place that problem, and in terms of C-peptide and insulins, we don't routinely check them either, because A, they're expensive, and B, it's difficult to know how to make sense of the data anyway, unless you've got a glucose level and a history of whatever background medication they're on. Short answer, feel free to use an SGLT2 inhibitor with comfort that you're gaining health.
Gaining health at the end of the day. So I'd want Dr. Roberta to give us a parting shot as we close. You've given your parting shots, by the way, FYI. Dr. Roberta?
Thank you so much for this opportunity. I want to say I appreciate every single person who has made time to be here. And I want to encourage you, as you see the patients, look beyond the numbers. Think about quality of life, not just quantity of life. But above all, I think we need to come together so we can have the necessary advocacy so that our governments can see that it is important to put the money where their mouth is. You know, it's just not good enough that we keep saying that the burden of non-communicable diseases in Sub-Saharan Africa is borne by people under 30. And I believe that advocacy is what will get us there. Thank you so much.
So the buck stops with us, right? And at the end of the day, what have we talked about? Quality of life. Don't treat the disease, treat the patient. Give them what's best. So I really want to give another round of applause to Dr. Roberta Lamptey, Professor Mark Evans, Professor Lassie. And in case you want to meet them, go to Mombasa. And I think you're going to be attending the KRA conference. I'd like to take the opportunity to invite you next year for the Kenya Diabetes Study Group, where we'll be talking about quality of life and health. And I can see you're very passionate about it. So, Anthony, I hope you're listening to this. No pressure, but we'll be expecting you next year. Otherwise, for those of you who are online, please scan the QR code. We'd like to have feedback with regards to having such sessions. I think we've had a wonderful session. You can tell from the presenters at some point, I think you forgot we were all there. And Mark and Ulasi were so excited. That tells you how passionate we are about improving care. So I'd like to hand over back to David, or is it Karen? BI team, we really want to thank you. We've had a wonderful time. We hoped we had actually wanted more time, but this has been fantastic. So thank you very much. And thank you to all our online participants.
Thank you, Dr. Ngugi. Thank you to our eminent advocates from across the region, regional speakers, local speakers. I'm seeing hugs here. I hope online. Dr. Roberta, we also appreciate you together with the Ghanaian attendants, Cameroonian as well as Nigerian across Sub-Saharan Africa. This is a CPD accredited event. Of course, feel free as well to get your tokens. I don't want to add any more, but what is my key takeaway is that there's a lot of discussion around what we can do from a GDMT application process. It starts with us. from a primary care perspective, let's treat the patient, let's walk the journey, let's advocate from the healthcare system, see where we can address the clinical inertia. Even in the US, we know DPP4 inhibitors are quite high at the radar. I don't know how the UK system is, but SGLT2 inhibitors together with the GLP-1s, these newer molecules, there's a lot of education that we require for a primary care perspective that we can drive. So let's encourage that multidisciplinary discussion. And I would like to thank KDSG for organizing this forum, partnering with Boehringer Ingelheim, and of course, appreciating our online attendees for bearing with us for the extra 30 minutes. We'd like to close this session here physically. Well, let's continue the discussion. For our online viewers as well, let's continue with the comments, chats, and we'll of course get back to your questions. So let me close this event and encourage the discussions to go on forward. Dinner is served here. And of course, be careful of what you take. Organ protection is key. HbA1c is key as well. Let's discuss cardiovascular kidney metabolic system. I'm surprised today you didn't mention that, Prof. Ulasi, because you are again a CRM, but talking for discussion. Maybe that's for crack on. But thank you all, a clap for everyone, and have a good evening to online attendees. Thank you for attendance and have a good evening. Bye-bye, everyone. Thank you.